Well, when Nikolai asked me to give a talk, and then I spoke with the organizer, they said that I need to give one AD talk, another one flu talk, but I do not know much about influenza. I work with influenza when I was like 19 years old, a couple of years, and after that I didn't do much. So I said, no, let me present something else if you need that. And they said, yeah, the tumor will be fine. It happens that we just published a new paper with targeting toll-like receptor 4 with a pharmaceutical-grade non-toxic agonist and in a mouse model of breast cancer, basically. So let me try to give you some information here. So unfortunately, breast cancer is the most common cancer in women, and we have about 1.7 million new cases diagnosed in 2012, and about 230,000 people died from new cases. Worldwide, 521,000 died in 2012, and in 2015, about 230,000 new cases of invasive breast cancer we are expecting in the U.S., and about 60,000 of, thank God, non-invasive. 5 years survival rate is good for the primary tumor when they found it's localized, and unfortunately, it's becoming much more terrible for with even local metastasis in lymph nodes and distant metastasis too, even more worse. So we just talk outside about the checkpoint inhibitors and this and that, and we do realize today that the immunotherapeutic strategy for the cancer, it looks like finally working. We work with that. I'm 65 years old, and I remember we were hoping that we can get the vaccine against tumor 40 years ago, and it never happened. Although we have now one vaccine of DC vaccine, which is not working very well in prostate cancer people stage 4. But the idea of immunotherapy is still exists, and it's becoming more and more interesting. So what we can see here is that the immune checkpoint inhibitor, anti-CTLA-4, anti-OX40, PD-L1, and PD-1, they are showing some interesting effects in humans, and although for breast cancer it's not used for right now. But it's still, there are many clinical trials with anti-CTLA-4, and I think a couple of trials with anti-PD-1. But we have monoclonal antibody against other HER2, which is probably will be next one. But there are also many vaccines which are DC vaccines, which is currently we are trying to use in clinical trials with NY-ESO specific antigen, for example, with TERT, very interesting clinical trials, and so on. So there is another interesting thing is that adaptive T-cell therapy, which is in many clinical trials, which at the beginning people thought that it never will work, and now it's one of the most interesting trials in which you can attach, have a two-armed, which you can attach T-cells and chimeric antigen receptors. So basically, it looks like immunotherapy is working, and I would like today to discuss the TLR4 agonist, which may be interesting for clinical trial. So as I said to you, monoclonal antibody are working with HER2-neo, mostly in breast cancer. And there are different monoclonal antibody which used in clinic, some of them binding receptors, some of them binding the dimeric molecule, which is binding both, and so on. But we thought that maybe TLR4 agonist may work because it's recognized, as you know, conserved pathogen-associated molecule pumps as well as danger molecules, damage-associated molecules pattern. And TLR also express and induce various cell types, including disease, T cell, macrophages, and tumor cells. Tumor cells is important to know because many people think that if they are induced in tumor cells, if we will use something which is activating TLR4, for example, or 2, or, we can also activate tumor cells. So that's important to know. There are many TLR4 agonists under investigation now, and 2 TLR4, as this is TLR2 BCG actually, TLR3, TLR4, and Imucromod TLR7 are approved by FDA at least for different types of cancer, but not breast cancer. So as you can see here, there are several TLRs which are on the surface of cells, and TLR2, 4, 5, and 6, whereas TLR3, 7, 8, 9, 12, 13 are inside on the surface of endosomes. There are also several TLR which present in mice we cannot find in human, and there are TLR10 expressed in human, and we don't know where is it. So the TLR4, for example, is mostly known because it's binding bacterial molecules. MPLA and LPS are one of them which are very, very famous and used for the TLR4, and it could activate the NYD88 adapter and activate NF-κB. So we decided to check TLR4 because the Immunomox is about 15 years are used for intramuscle injection in 5 different countries. It was discovered by my friend, immunologist, a good immunologist in Russia, in Moscow. And then later on, it was licensed with 5 different small countries. And it was used for as antiviral agent, actually, antibacterial agent, because that was non-specific immunostimulator. But we started to think about that and say, let's see what is exactly it's working, how it's working, and what it's doing. And we tried to use a HEC293 cells line, which is expressing different TLRs. And as you can see, we try to activate, we'll try to add the medium or Immunomox or a positive control TLR4 agonist. In each case, a TLR4 agonist, which we activated a specific TLR. As you can see, all agonists are activating whatever they need to activate, but only TLR4 activated with lipopolysaccharide and with Immunomox. So LPS and Immunomox is doing the same thing. So LPS and Immunomox both should be TLR4 agonists. And if you look for the LPS and Immunomox and see how NF-κB activated by Western blot, you can see both of them is here activating with LPS. This is lane 2, and lane 3 is LPS. I'm sorry, 2 is Immunomox and 3 is LPS. So then to be sure that it is binding to TLR4, we use a peptide which is known to inhibit binding to TLR4. As you can see here, when we seek the IL-12 production in bone marrow-derived cells, we can see when we add the Immunomox, we got activation. We add the inhibitor of binding, and we see inhibition. So it's specific to TLR4, and it's binding to TLR4, and therefore we make a decision that this is TLR4 agonist. This is new TLR4 agonist. This is not from bacteria. This is from potatoes, and therefore it should not be as toxic as LPS or MPLA. And MPLA is used in many clinical trials today, including cancer clinical trials for cancer patients. So we decided next, before this talk was questioned how immunotherapy is working, you need to be sure that the epitope is right and if epitope is wrong. So obviously to see the immunotherapy is good, you need to have an animal model which shows that it's working. One of such model is 41 mouse model of breast cancer. That's spontaneous metastatic model from biopsy mice. It was generated in 1988. And fortunately, this model is very, very close, fortunately to humans and unfortunately for mice. It's very, very close to the human breast cancer. So it is not, when you put it this tiny amount of cells, we put even 3,000 cells, it worked. You put it in a memory pad, in 22 days, you can find the metastatic disease in liver, lungs, even bone and brain, which is very important for the testing of any immunotherapy. If you will even take out the primary tumor, 100% mice will die from metastatic tumor, metastatic disease, I'm sorry. So we use this metastatic model to test the efficacy of Immunomox, and we showed that 35% of mice, after removing of primary tumor here, they survived for 140 days. I didn't show it here, but if we will inject here tumor again, so all mice will die. So there's no memory, no specific immune responses. There is just a drug which is helping to cure metastatic disease, and mice can live probably 2 years or whatever without problem. So experiment was done this way. So we injected 41 in memory pad. In -9 day, we can feel, we can feel the tumor because it's palpable. And immediately after that, we're starting injection of Immunomox. And on day 3, we took out surgically removed primary tumor. And then we check, we terminated animals and detect the immune responses here and detects number of clonogenic metastasis in the lung. So we can see some, not very significant, but it's still significant, decrease of number of clonogenic metastasis after injection of Immunomox, if we compare with control. So if we will go to the survival, as I said, 31% animals will survive. And then we decided to check, okay, now let's see how we can increase, could we see the increase of frequency of activated NK cell, CD4 cells, and CD8 effector cells. And we found that all of them are increased. And here is data with FOX analysis. We will check frequency of CD69 positive cells in a population of NK cells, in a population of CD4 cells, and population of CD8 cells. But next, we asked the question, is that somehow affect also the suppressor cells? And we checked myeloid suppressor cells, and we checked the regulatory T cells. And again, we saw the myeloid suppressor cells will have differences here, but no differences in regulatory T cells. So therefore, we can conclude that we basically, Immunomox can block at least partially suppression, and blocking of suppression, we can push activation effector cells and takes out the scale to put it in the right direction, or better to this even direction, so which immune system can fight the metastatic disease. So then we studied the mechanism of action because we thought that the effect of Immunomox would be through the activation of NK cells or through the activation of DC and macrophages. So here we can see that when we have effector-target ratio in rich mouse NK cells, this is enriched mouse NK cells, and this is enriched mouse NK cells in which we mix with short explaining dendritic cells. If we have a dendritic cells, efficacy is much higher of NK cells will kill the target YAC1 cells here. And if the same here with CD69 positive NK cells, we can see that if we add the DC, the effect is much higher. So basically, NK cells were activated, but not as good without DC. It doesn't work very well. So we need to activate DC, and through the DC, activate NK cells, and NK cells will kill the tumor And the same thing which shows as with human peripheral blood mononuclear cells. We have now many data with cancer cell, PBMC from cancer patient and PBMC from healthy people. And in all cases, if we will add the whole blood, activate with Immunomox, efficacy is much higher than if we will use a medium. So even whole blood is working very well. And if we enrich NK population, and enriched population is not working as well as whole blood, which is telling exactly the same data which we got with mouse. So actually, we need DC to get the better activation. Immunomox also induced proliferation of mouse DX5 NK cells through the activation of bone marrow-derived cells. Again, we can see the activation of the percent of divided NK cells after activation with Immunomox, and this is medium, and this is just we show how we purified the DX5 positive cells. So next, I would like to show that the Immunomox significantly increased the ability of mouse NK cells in bone marrow-derived culture to inhibit the growth of 41 GFP tumor cells. As you can see here, 41 GFP cells pair well. We can see here that when we have 41, we have NK cells sorted bone marrow-derived cells, and Immunomox. This is the best situation when we have DC, NK cells, Immunomox, and 41 GFP cells. So we can basically, having GFP, we can really see the number of cells in vitro. So conclusion, Immunomox does not activate NK cells directly, but it activates NK cells through the DC-mediated. Activation of NK cells by both mouse and human DC pre-activated with Immunomox is significantly more efficient than in non-activated DC. So basically, we decided to check the next, could we use how we activate the DC, what we can see. So we can see CD86, basically the same data with CD80 activation and IL-12 cytokine in bone marrow mouse DC. So this is IL-12, this is CD86 activation, and here is the same thing with percent of the cells. And then Immunomox activated also human TLR4 positive myeloid DC, but not plasmacytoid DC. Yes, you know myeloid DC, they have TLR4, while the plasmacytoid DC, they don't have TLR4, but they can be activated by TLR9 CpG agonist. So you can see we can activate plasmacytoid DC with CpG, but not with Immunomox. And the other way around, we can activate myeloid disease by Immunomox. And then we show that Immunomox is also activated pro-inflammatory cytokines, IL-1 beta, TNF-alpha, and IL-18, along with interferon gamma and IL-12. Also, Immunomox activated human monocyte-derived DC killed by, they killed by 562 mild leukemia and 41 breast cancer cells. This is an interesting thing because basically we do not need any HLA restriction here. There is no restriction here. DC can kill, human DC can kill mouse tumor, and mouse DC can kill human tumor. Of course, it's not practical in clinic, but interestingly that you can basically use DC to kill every tumor, whatever you want to. And here you can see this is tumor cells, this is DC, and this is Immunomox. It's killing this one, and it's also killing mouse DC. This is human DC, which is killing the mouse tumor cells. Killing capacity of hormone depends on the doses of Immunomox. When we go 15 microgram per ml, here we're probably coming to the plateau. We get as much killing as possible with higher doses of Immunomox. A mouse bone marrow DC activated with Immunomox acquired cytotoxic activity and become killer DC. This is another thing which is, we knew that many years ago from 1980s, and now we're learning again that dendritic cell can kill directly tumor without any help from CD8 cells or NK cells. they call killer DC. It's already, there are many publications for that, and it's continue to be more and more publication. And we check that, and we can see that, yes, Immunomox is activating purified DC, and we can see the killing of the cells here. And this is just GFP41 cells, which you can see here with Immunomox. They are almost destroyed, and this is cells which are killing tumors. So as I said to you, Immunomox transformed mouse bone marrow-derived DC and human myeloid DC. Immunomox transforms them to the killer DC that are capable of directly killing the syngeneic and xenogenic tumor cells. As I said, there are many interesting publications which is showing the direct killing. And this data and published result opening, I think, new avenue for development of the novel cancer immunotherapeutic strategy and personalized immunotherapy with DC-activated ex vivo as Immunomox. Of course, you can envision also to add to that some specific antigen, and that DC will do the two function. In the one hand, this DC will activate the CD8 cells, and they will kill the tumor. And on the other hand, this DC directly will kill the tumor. So it's an interesting strategy. We are now trying to check in their different models, mouse models, and go to clinical trial because, as I said, this Immunomox is 15 years used in human. So we have hopes that Ravshan Atalakhanov, he is the guy who basically discovered this Immunomox and isolated this from potatoes. His group at the Institute of Immunology in Moscow is working with many different good scientists in the United States. My alma mater, Gamaleya Research Institute, we have a couple of people there who work there. Dr. Edward Nelson is immunologist and head of the oncology and hematology department at University of California. He is planning to start clinical trial with that. And this is my group who is working with this Immunomox model and mouse model of breast cancer. Thank you for your attention.